Everything ready?
Yes, yes, we are getting almost.
Almost.
Good to hear from you, Judith.
Yeah, nice to hear from you, Pat, and all of you. It's great. Sarah, the slides are really clear. Don't worry, we can see them. So
great.
Yeah. I can see Eunice, see May, I can see Thin.
what's going on now?
Great.
Yeah.
Hi, Godwin.
Hi, Thin.
Godwin.
Hello. This is Dr. Joseph. Oh, how are
Hi,
you?
how are you? How's everybody?
Well, thank you, Dr. Joseph.
Hi, Joseph. It's Judith. Nice to speak to you.
Hi, hi,
Hi, Dr.
Judith.
Yusuf.
Hi, hi.
How's Myanmar, Thin? The figures yesterday didn't look good. How are you doing?
Oh, not at all. Last couple of weeks, we only had 300 cases, and now we have gone past 1,000 cases. And so it seems like it's spreading quite quickly in Yangon and Rakhine.
Yeah. Yeah, I saw the graph. It was very impressive. A vertical line going straight up. You thought, oh, blimey. No. Oh, well, keep us informed, Finn. Keep us informed.
Thank you.
Keep yourself safe.
Will do. Thank you.
Yeah, it's a bit annoying because she could have just replied to the email.
Hello, this is Rob. Sorry I'm late. Can you hear me?
Yes. Hi, Rob.
Oh,
This
yes.
is Sarah. How are
Hi,
you?
Rob.
Hi, Sarah. Hi, Godwin. Sorry, I'm a couple of minutes late.
Oh, no
Apologies.
problem. We're still waiting for a couple
It's okay.
to join.
Still waiting, couple of people to join, so it's fine. How is Nairobi, Rob?
Okay, good.
Are you in Nairobi?
Yeah, it's okay. Yes, Nairobi is fine. You know, kind of waiting for winter to end in a way. But yeah, all things considered, it's okay. How is Dar?
Dar es Salaam is good. It's fine. We are doing fine. All is well. We are just looking forward to the elections very soon. So campaigns have started.
Oh, yes.
It's quite a busy moment now in Dar and other parts of Tanzania. Yeah.
Another term for the big man.
Yes, definitely.
Sarah, did you get there was a small change to, I think, to one of the bullet points on the last slide, and I just, in the interest of, in haste, sent it to you a few minutes ago. Did you receive it?
No, I've been on this call, but I can replace it right now.
Okay.
Okay, I just got it. Let me just share my screen. Okay. So I think we can begin now. We have about 19 participants, which is great. I know I've gotten a lot of out of office replies, and of course this presentation talk will be recorded and posted on Workplace for colleagues who are unable to join. So just give me 1 second and let me know if you can see my screen. Okay.
Yep.
Can everyone see this?
Yeah.
All right. Go ahead, Godwin. He's going to make the introduction for our presenter today.
Yes, thank you, Sarah. Good morning, everyone. Good afternoon from Tanzania. And thanks everyone for joining this session today. We are here to talk about, to hear from our consultants on the results, on the findings of the program evaluation, which was done quite recently for the community-based health program, which was implemented in Tanzania for the past 4 years. So we have the team of consultants led by Rob Hoods, based in Nairobi, and Caroline, and the two colleagues based in Tanzania, Suleiman and Dr. Grace Koro. So before I welcome the consultants, I would like to say just a few words, a couple of, just a quick background of this program for the benefit of those who are not aware about the community-based health program in Tanzania. So this program was implemented, it started in 2016, and it's funded by Comic Relief. The objective of the program was to support the Ministry of Health to roll out the formal community health worker cadre in Tanzania. So the project was focusing on building capacity of the national level, the Lake Zone training institutions and councils to be able to implement the community-based health program strategic plan 2015-2020. The scope of the program was actually covering 10 health training institutions, which are producing formal community health workers in 5 regions based in the Lake Zone of Tanzania: Mwanza, Kagera, Simiu, Geita, and Shinyanga. In terms of the activities, so it was a multi-level approach program. We worked at the national level. We supported policy development related to community-based health programs. We supported strategies, policies, and guidelines. We also supported some training-related activities. So we did capacity assessments of health training institutions which are delivering community health workers. We also provided orientation to the tutors on the curriculum for community health workers. But we also had interest in supporting, in building capacity of regional and district health managers across the 5 regions that THET was working on. And the project was, just to mention, that was implemented in collaboration with our local partner called Benjamin Mkapa Foundation. Just to add on that, we had a sort of 2 phases of the program. So we had the first 3 years is what I was explaining now, and we had another year, 1 year, which is a no cost extension. And the focus of this 1 year was mainly on gathering evidence on the value of community health workers, and also we had a interest on quality of the in-service community health workers. So we had some interventions related to quality improvement for the community health workers. We also managed to deploy 60 community health workers in one district of the Lake Zone called Magu district. I think that's a quick overview about the program. I would like now to welcome the consultants led by Rob Hoods to deliver this presentation, to tell us what transpired from the findings, and more important, what are the recommendations that would help to shape our thinking and inform future programs for THET in Tanzania, but also across other countries that THET is operating. So thank you very much, team, Rob and the team. Over to you now. Thank you.
Thank you, Godwin. Good morning, everybody. Good afternoon, depending on where you're located. Thank you very much for the opportunity to go through and present the evaluation of the community-based health program. Apologies that we were not able to make last week's slot. So thank you for your flexibility. At our end, we have Caroline Kosalai, who's one of our program associates, and Salamani, Tanzanian associate of ours, who the wider Tanzania CHW program for quite some time. The evaluation. Sarah, can you hear? If you can hear, could we go to the next slide, please?
Yeah, sorry, Rob. I think there's a little bit of bad connection perhaps on your side. There was a bit of a delay, but now I think it's back to normal, hopefully.
Okay, can you
yeah.
hear me now?
Yeah, right now it's great. Thank you. Sorry about that.
Okay, very good. No, thank you. Okay, so we're going to run through sort of 5 sections to the presentation. We'll give a very, Goldwyn's already given an overview, but we'll just kind of summarize a bit more context and introduction, and then we'll get stuck into the evaluation overview and the findings, and then more importantly, looking at some of the key lessons or some of the key learnings and practices, and thinking about potential recommendations for the future, not only for community-based health programs in Tanzania, but also perhaps for other countries that THET works in as well. Next, please, Sarah. And you can skip through this one as well. So thank you. So obviously, I mean, in Tanzania, a lot of community-based health challenges, which are very relevant for community health workers and community health worker programs. I think it's fair to say many of the challenges are obviously exacerbated by shortages of skilled personnel down at the primary healthcare level and community level, which obviously affects health service delivery, demand and supply. And there's obviously lots of weak links between referrals from a community level to formal healthcare delivery at dispensaries and facilities and beyond. Interestingly, the community-based health program in Tanzania, as many of you know, goes back for many, many years, all the way to 1967, when it was really taken up as a key strategy for healthcare delivery. Next slide, please. That said, community health workers were never institutionalized formally into the official cadre of human resources for health. And it was only until 2015, when the community-based health program strategic plan was launched, that there was a real intention from the government to actually formally introduce CHWs who would be formally trained, institutionalized and mainstreamed within into the human resource network and cadre overall. So that's essentially when the comic relief, I think it was opportune timing with the wide comic relief call, which THET and Benjamin Mkapa Foundation applied for, was to really support the government of Tanzania to carry forwards that formalization, that of training and institutionalizing and having CHWs built into the health workforce. And the program started in April 2016, ran to March 2019. So we had a full 3 years of implementation, and then that was extended out by a 1-year no-cost extension, which ran until March of this year. Okay, so a bit of quick background. In terms of the evaluation, I won't run through this in detail. I think it's fair to say that we followed a fairly standard evaluation methodology with questions all based around the OECD DAC criteria, which I'll run through in a moment. We carried out the evaluation starting around March, April time, which was really at the beginning of COVID starting in East Africa. And so we had originally planned to carry out a lot of work on the ground, but with COVID limitations, we had a mixed approach where we had a couple of very good local enumerators and data collectors who were able to carry out a lot of key informant interviews and focus groups with beneficiaries, and also then with coupling that with remote interviews carried out by myself and Salamani and Grace with key informants either down in Lake Zone or in Dar as well. So we had to tweak our methodology based upon the situation, the changing situation on the ground due to COVID. Let's go to the next slide, please, Sarah. So we split the evaluation up into three main phases, essentially looking at the first phase of preparation and sort of the inception for the evaluation. We produced a detailed inception report and all of the tools which we shared with THET before going into phase 2, which was really primary data collection, and then phase 3 on the data analysis and the report writing as well. So in terms of the key findings, so we've aligned a few slides here to the OECD DAC criteria against which the evaluation was carried out. So in terms of the relevance of the program and the interventions, I think it's fair to say that the program overall was very relevant, particularly in the first phase, or if you like, of the program. So the program supported the implementation of the community-based health program policy or the strategy at the right time. It's when support was really being requested by the government, so it was opportune and relevant timing for THET to be providing additional support to the government to launch and expand and roll out the strategy as well. Secondly, I think it was very clear from all of our interviews and meetings and conversations with all levels of stakeholders, I think even from community stakeholders all the way through to development partners and government officials, everyone more or less said that the intervention was relevant and appropriate, and very much aligned with the national and regional strategies. There was very little. That was a very clear message that came out about the overall relevance of the interventions and the timeliness. And I think, coupled with that, I think just a very strong message that came out from stakeholders about how the way in which the program was aligned very well to the strategy and to the strategic priorities for the government as well. Even, I think it's fair to say, even when the program, the government program, the strategy changed, THET was able to, and the program was able to sort of reduce down some of its interventions, so it was very well aligned to the changing priorities of the government as well. Next slide, please. I think also in terms of the relevance of the intervention down at the Lake Zone, I think the choice of Lake Zone was very relevant, particularly with Lake Zone having some of the worst indicators at different levels. So obviously the importance of having CHWs deployed at Lake Zone, very, very, very critical. I think in terms of, there was obviously a shift in the shift from the government in terms of their priority for the community-based health worker program, which we'll cover in a few slides. And when the decision was made to go back to a volunteerism model instead of having CHWs formally trained and institutionalized as part of the paid health workforce. Despite that, I think it's fair to say that the program was still able to remain largely relevant, even though the scope of work had changed quite significantly. And as Godwin just mentioned a few minutes ago, I think a lot of the relevance really came because there was a shift in the no-cost extension phase to really look at how what was the evidence, what were the lessons, what was the evidence that had come out of the program so far, to really think about was there a different way of being able to support CHWs despite the changes. that had taken place at the sort of at the government kind of level. So looking at some of the evidence about the quality, but also focusing on some of the quality improvements as well, quality improvement for CHW performance and delivery at the community level. So overall, very relevant, I think it's fair to say. Next slide, Sarah, please. In terms of the effectiveness, I think, again, the program was largely effective in terms of how it was determined, how the effectiveness was going to be determined. So if you look at, looking at some of the quantity, looking at the log frame and the M&E plan, I think looking at the indicators that were achieved overall, 10 out of 14 of the indicators, of the quantitative indicators were achieved. 4 were not, but I think overall, effective program delivery as defined by the log frame. That said, there were quite a few qualitative indicators, 9 in total, I think, which didn't have clear targets set. So it obviously makes it very difficult to measure how effectively those qualitative indicators were acted upon, or how the program delivered against those qualitative indicators. And we'll talk a little bit more soon about some of the monitoring and evaluation on the program as well. And I think finally, I think for the no cost extension, I think it's fair to say that most of the activities at the outcome level were successfully carried out as well. Some were not, again, impacts of COVID going into the final few weeks and months of the no cost extension. So there were some delays, but overall, I think as far as we could determine, the no cost extension was justified and effective. I've already spoken about the collaborations with the Ministry of Health and other stakeholders. It was clearly an effective collaboration, as was the operationalization or the support to really make that CHW CADA more formalized and operational until the changes. And I think, from the discussions that our team had with community beneficiaries, and I won't read the quote out below, it was very clear that communities did feel the impact of the program and did, the interventions were certainly effective, and certainly effective before changes at the government level led to a shift in the way in which the program needed to be, the overall community-based health program, not just THETs, but the overall program needed to be implemented. A few areas that were maybe not as effective on the program, and we can talk about these a little bit more towards the end. So some of the data inconsistencies, so sort of ineffective data use, the way in which the M&E plan was perhaps compiled and then used, so it affected some of the data quality and affected some of the way in which we could carry out the evaluation. I think there were some changes to the program team over the 3 to 4 years of the program. A bit of an institutional memory gap, perhaps, to some degree. And I think that's also coupled, perhaps, it has linkages to some of the data inconsistencies as well. And I think the other thing, not a huge area of ineffectiveness necessarily, but I think some of the program targets at the beginning were quite low, but these were subsequently corrected by both THET and BMF partner throughout the program. So again, some good use of flexible, sort of adaptive ways of programming. In terms of efficiency, I think it's fair to say the action plan that was developed was realistic and it was achieved in an efficient manner. Some of the activities were not realized on time, but obviously when you're working with multiple stakeholders and working with Ministry of Health on a complex program like the community-based program, we are always at the beck and call or slightly dependent on externalities, which the program was, and therefore led to some delays. Importantly, though, I think that because I think there was a bit of a sorry, can you hear me?
Yeah.
Yeah. Okay. Sorry, I could hear a microphone. I was assuming someone was going to say something.
No. Okay.
I think importantly in terms of efficiency, though, I think that you know, it wasn't entirely attributable to this program and THET alone, but I think there was a kind of a catalytic effect in some way because of the investments that Comic Relief made through the THET program to support the training and institutionalization of CHWs, and you know, this kind of led to it played a role in increasing momentum for others like USAID and the World Bank and Irish Aid to also then co-support and co-finance training and institutionalization for other CHWs as well. So I think, you know, if you think about some of the, a relatively small amount of money from Comic Relief being able to kind of play a catalytic effect to some degree to unlock finances available from some of the bigger players and development partners in the country, I think that's a really important sort of efficiency gain that the program was able to bring into effect. Next slide, please, Sarah. Thank you. So I think I've already said the first point here about sort of the synergistic, I think it's meant to say, synergistic effect in the way in which funds were leveraged. But I think it's also fair to say in terms of at the community level and collaborations, I think that there was an efficient way in which the program strengthened linkages and collaborations down at the community level, and that also helped to deploy other CHWs, certainly in Magu district as well. I think if you look at the quote at the bottom there from an Irish Aid, from one of the Irish Aid respondents, I think it makes it very clear about, you know, just the way in which all of the partners that had been working on the community-based program efficiently worked together, and that was sort of the results of that were only achieved because of the efficiencies of working together as opposed to just working as one or two individual stakeholders. Please. In terms of impact, quite difficult to ascertain the overall impact, and I suppose it was partly because of changes, but also some of the impact level indicators were not necessarily carved out as clearly at the beginning as they could have been. I think though, in terms of some of the key areas of impact, you know, results that have had sort of the most tangible impact, I think it was came out clearly to us that there were areas of improvement in hygiene and sanitation, which could be attributed to CHW health promotion activities. I think there was, you know, there was a noticeable improvement, and this noticeable certainly for a lot of respondents for the that took part of the evaluation, noticeable improvements in the health and well-being of pregnant mothers, again, which can be attributed to home visits from CHWs, and certainly improved capacity of health training institutions to implement the curriculum and curriculum-based trainings, which of course was a significant part of the program being focused on training and capacity building. Sustainability. So, I mean, I think it's fair to say that obviously working to support government institutions like the Ministry of Health and other institutions, it's really building upon existing structures and formalities as well, and obviously providing a lot of TA and support and capacity building into those institutions certainly increases to some degree of sustainability. I think, however, it's obviously given the pivoting of the strategic plan to move back to volunteerism as opposed to a paid cadre of staffing, made the longer term vision of how the program would run and be sustainable in the long term very challenging. That said, I think that, you know, I think the way in which the program used the no-cost extension year to gather more evidence on some innovative ideas and looking more broadly at what might be some of the different more sustainable models for CHW programs in Tanzania was a very useful thing to do in that no-cost extension year. And it will be interesting, I think, to see what the impact might be on future programs from that that comes out of the no-cost extension. I think it's important to say, though, this issue of sustainability on a 3-year program, you know, what is ultimately going to be sustainable is always comes with many caveats. So I'd like to sort of, I'm using the word sustainable here simply because it's part of the questions that we were trying to answer, but I'm based very much in realism about what is possible over any kind of duration as well. Final few slides now. In terms of gender equity and gender, important consideration. So I've already mentioned about obviously the program working in Lake Zone, having some of the worst health indicators. So in terms of equity and really going into some of the, you know, the hardest places or the places with the worst indicators, certainly that was something that the program did very well. The training, obviously, as I mentioned a couple of slides ago, helped to increase the health status for some of the more vulnerable groups, including women under fives. There was certainly some awareness increase by men on sensitive issues such as reproductive health and family planning, again, which really came out clearly was because of the engagements with the CHWs. However, one of the areas that the program, and this is not, you know, any fault of the program, it's just it's sort of societally sort of attributed in a way, I suppose, is around there were effectively more male community health workers supported by the program than female, and this largely comes down to the fact that more men are more qualified because they've been in school for longer, they're being given more life chances, and ended up coming out with more qualifications which met the requirements for the CHWs than many of their female counterparts. And also, as we know, you know, men often are the ones that have more access to finances than their female counterparts, and so it also enabled more men than women to be able to pay the tuition fees to then be to then become qualified CHWs. Value for money, there wasn't a value for money framework developed on the program. It wasn't a requirement from Comic Relief, and so what we were asked to do was to think about, thinking to the future, what kind of, would there be some value for money indicators that might be useful for a future community-based health program. I'm not going to go through those in detail. I think it's they're fairly clear suggestions. I think it's more important just to say that there aren't, the value for money in community-based health programs, there aren't many standard indicators out there for value for money. There's quite a lot on cost effectiveness, about the, you know, the cost of delivering a service through a CHW as opposed to other means. And I think it's fair to say CHW programs offer good cost effectiveness in that sense, but there isn't really a sort of standard set of indicators, VFM indicators for community-based health programs. But the list here, I think, are could be quite useful and quite certainly sensible and rational, that might be of some useful consideration for future programs that THET and others may implement at the community level. Final few slides on learnings and best practices. So I think I hope it's come out clearly from the last few slides that it was obviously critical to build these synergies with stakeholders, to build up the momentum, which THET and others were able to do, not working in silos, and being able to, you know, coalesce and create greater results because of multiple partnerships and greater momentum. So it's obvious in many ways, but I think certainly when you're working at supporting a large-scale program like this in Tanzania, and we often work in consortiums, but outside of our consortiums, to have a much bigger, wider approach, strategic alliances, than just the 2 or 3 organizations which are working under our consortium umbrella. I think there's a need. So one of the learnings was really around there is a need for, there has been a need, or there was a need on this program at least, for stronger monitoring and evaluation, and or monitoring, learning and evaluation. It was something that we discussed quite a bit actually with Godwin and also with Amma throughout the evaluation. It seems as a lot of, there's been more reinforcements put into the monitoring and evaluation at THET, which is good to hear. And I think another sort of key learning from this was just that the program was well designed. It was well rounded, and it was able to deliver what it was meant to do, and it even managed to withstand some of the shocks from the change in the strategy. If you go over the slide, Sarah, to the next one. Yeah, so the first point here is about adaptive programming. So even though it was, I think it was fair to say it was a well-rounded program design, but it was able to be adaptive and kind of change and shift and modify itself. And this is as much a reflection on Comic Relief as it might be on the THET team, but there was enough space and flexibility for the program under THET's leadership to be able to change and pivot to be able to meet the changing needs of the larger strategy. A key learning also on harmonizing different cadres of CHW was critical to make sure that everyone that was a CHW, so there was equity and satisfaction to ensure effective delivery of the program, as opposed to having different people on different levels. And the final point here, which is really around community engagement and ownership. It was really critical for CHWs to be owned and be perceived by communities to be owned and to be a resource person, essentially. Just being really critical to help build up more support and use and ownership of CHWs at the community level, as opposed to kind of being seen to be sort of a formal structure or formal provider that necessarily doesn't serve the needs of each community that they work within. Next slide, please. So a few final recommendations. So I think there's obviously this applies not just to THET and this program, but to others as well. I think it was very clear to us that there's a lot of evidence out there on and best practices and on how to the processes to design and roll out CHW programs at scale. I found it fascinating myself going through a lot of this stuff, but it made me then kind of, when I applied this to the Tanzanian context, it made me realize how much hadn't really been applied to in Tanzania, particularly things like costings. Costing of CHW programs, they're absolutely enormous, and it seems as though there was very little attention paid to costing in Tanzania before the program was tried to be rolled out, and that obviously led to a huge roadblock for the program. So I think just greater use of evidence and learnings from other countries to design and roll out CHW programs. This doesn't just apply to Tanzania. It doesn't, of course, just apply to THET, but it's a key recommendation for anyone else working on CHW programs. There's a need to strengthen the M&E function, which I've just mentioned as well, and that seems to be being addressed, which is great. And I think another recommendation was just around the log frame, so linked again to monitoring and evaluation. I think just there's a need to adapt and develop program log frames that are used as living documents. They're used to monitor the performance of programs. They're used in an adaptive way, that they're changed as and when needed in consultation with the donor, so that we can objectively define how progress quantitatively and qualitatively is being made. And I think it's important to, I've already made the final point about partners owning CHWs in the communities, and reinforcing that community ownership is just critical for better service delivery, better client facing or sort of community client relationships, and also leading to hopefully more sustainability for future programs. And I think this is now the final slide. So it's important for communities to own CHWs and to have that perception of ownership, but it's also important for in-charges and facilities to be much more involved and sensitized on CHWs, particularly because they are overseeing, coordinating their catchment areas. Similarly, I think that there's a need for mapping of CHWs within the catchment areas to really strengthen their coordination. And this can be all different sectors, including public sector and private, to really understand where the CHWs are located, so that the referrals between different levels and between different facilities can be more effective. LGAs may want to think about strengthening village reflection meetings to really provide that feedback and that sort of that feedback loop from the community back to local government authorities. And going back to Godwin's point from the very beginning about the no-cost extension and strengthening quality of service provision, it is obviously a key thing that it's a constant need, particularly with retention or with dropout and new CHWs coming in. It's a constant thing that has to be done in programs to make sure that CHWs are providing the quality of services that are expected. So thank you very much. That's all from me for now.
Thank you so much, Rob, for this really great presentation. It's really interesting to hear about all the results, especially because there were multiple evaluations going on at THET, specifically at the same time. And I know COVID did pose a lot of hardships and some limitations, but it seems like you and your team did a very successful evaluation. I've also shared the executive summary with the rest of the colleagues, and I'll be posting it on Workplace again. So thank you very much. And so now we have about 15 minutes for questions. So if you have a question, just go ahead and unmute yourselves and yeah, ask away. Thank you.
Rob, can I start then as chair of THET? That was superb, really, really good. And the reason I say that is because the trustees had great concern, as everybody knows, when we got to the point of really affordability by the government when you've done the training, and it was all this cost benefit and proper costings at the beginning with the government when we're having these contracts. So you answered all those questions. It's funny really, Rob, it's rare that you listen to something and all the way through I was making notes of points like, I don't know, MEL and qualitative measures and all the rest of it, and you had them all in the recommendations. So that's great because it saves me asking any of those questions.
Brilliant, perfect.
Can I ask that whoever's got the power to do this, can this recording of the whole thing go to the trustees, please? Because there were two trustees in particular who are really concerned about how THET plans these programs with the partners because of that cost benefit element and of course the MEL element as well. So I'd be really grateful. I don't know who wants to hide on that, Louise, but somebody needs to just send it out to the trustees because it will phenomenally answer their concerns, Rob. So thank you very much for that, because it's always a concern. We have people who've never worked in developing countries, so they just couldn't understand why, having done all this work, the government then went into a volunteering mode instead. And we were all
yes, I think particularly for the context of Tanzania as well. No, but it's great. Thank you very much. And I'd just like to say as well, I think it's great that there are trustees on this call. So well done, THET, and well done, trustees.
That's fine. That's good. So thank you. The other thing is, I was going to say, Godwin, I'm sure that you and Dr. Joseph work well on this. I just wonder what Dr. Joseph felt about this, because having observed some of the community work going on in Ethiopia, and that last bit on the VFM side and the indicators, I just looked and thought, gosh, we need this. I wondered what Dr. Joseph felt about this. Are you there, Joseph? Can you help? I don't know who's there or not.
Just to jump in, he is on the call, but I don't think he hasn't unmuted himself.
Right,
so he may not be, his connection has been quite poor of late, so he may not be able to hear or respond.
It's always a connection problem, Louise, I have to say. So. Yeah. Okay, no, that's fine. But no, thanks again, Rob. That's great.
But if I could just add a follow-on point, and Rob, it's nice to see you again. We met in Arnhem for the Shine Supply. For everyone that,
yes,
if you don't know that,
nice to be in touch again, Louise.
Yeah, Rob is involved in the Shine Supply program that we work on in Somalia. So yeah, thank you. That was really fascinating and really thorough. So yeah, really great to hear that. And thank you to the team for managing to complete this under, oh, there's Dr. Yosef. Maybe I'll hand over to Dr. Yosef now if he's able to jump in. He's our Ethiopia country director, and then just come back on a further point, following on from Judith's point. Yes, over to you, Yosef.
Thank you very much, Rob. I'm Yosef from Ethiopia. I think it's a very lucid, a very useful presentation. In probably 6 months to 10 months time, we will be conducting our internal evaluation, as well as the Ministry of Health will be evaluating also the project. So there are some useful lessons to learn from that. It would be nice, just a suggestion, would be nice to share the slides with each of us. And also the questions I have, the questionnaires you used, the methodology you used, if we can get, in some more detail how you conducted the evaluation and the instruments you used, it would be quite useful for us to adapt some of the techniques you've been using for our evaluation.
Great.
Thank you.
Yeah, very good.
To you, Luis.
Very nice to hear about things being, useful replication for other countries and other programs, which is great. So yeah, so the inception report and all of the tools and the full evaluation report are with THET in the UK and with Goldwyn and team. But if they're not quickly available for whatever reason, we can resend them, including these slides as well. So Sarah, if you need anything that you maybe don't have access to immediately, just let us know and we'll resend them. But I'm happy to hear that they might be of some use in Ethiopia. Great.
Yes.
That sounds.
Sorry, go ahead, Louise.
No, that sounds great. So just to pick up on my my other point, it was building on Judith's point about the challenge of the change in direction of the Ministry of Health, but I suppose it was as you were saying, the lack of analysis beforehand of the cost of rolling out a fully funded formal cadre of CHWs. Is there more that THET could have done? I'm sure there is, but it'd be good to hear your perspective on what THET could or should have done at the beginning to really explore the likelihood of this cadre being able to progress based on the underlying challenge of it never really being affordable.
It's a very good question, Louise. I mean, we spoke to Goldwyn about we tried to really understand this a little bit more, speaking with Goldwyn and team through various interviews. And I think to be fair, the train had kind of left the station a little bit on this. And please, Salamani, if you're on the call and you have any other opinions, please jump in. But I mean, from our discussions and my discussions and my role on this on this evaluation, I think the train had kind of left the station. The strategy was kind of done. It had been launched with quite a lot of fanfare, and then that presented the opportunity for THET and other partners to be providing support. And I think Goldwyn, Goldwyn, you started a few months after this program started, and so I don't. So Goldwyn started after the program had already been launched. So we don't have any. I'm not privy, unfortunately, to the predecessor and what THET did then or could have done with regards to influencing the strategy and the rollout and any missed opportunities. I think it is fair to say, though, and this is based on really good conversations we had with Goldwyn, is, as always with many of these things, it can often depend on personalities. And I think there were some changes at the ministry and very senior ministers or cabinet secretaries and senior people in ministry sort of changing. And so I think, pet projects being well supported at the beginning can often become the thing that your successor wants to change and derail for various reasons, apart from maybe, you know, health impacts or even costings of these kind of things. And that certainly seemed to happen with this strategy. So I think I think in some ways there was probably very little that THET and others could have done for all of those reasons. It was about trying to manage a slightly unexpected, abrupt U-turn that was probably more politically motivated than because of anything that THET or others could have done but didn't do leading up to the design of the strategy. I think that's probably about as much as I can say on it, Louise.
Thank
Yes,
you.
sorry.
Can I compliment? Hello?
All right.
Yeah. Hello?
Hi. Salamani.
Hi. Hi.
Go
No,
ahead.
that is Godwin.
Then probably I'll come. I'll chip in. Compliment. Hi, Salman.
Hi. You know, from my opinion, I think when you look at the relevance of this project at the time when it was initiated, it was perfect. It was timely. It was going to give answers to questions that the government was asking itself. It was the time when the country has generated quite enough evidence to show that the type of community health workers who were used to work as volunteers is no longer a priority in the country, because nobody can work voluntarily in a lifetime. So there was a general consensus across all stakeholders, led by the government itself, that it is now new time to move into a different type of community health workers with some sort of incentive. And a lot of processes have been taken place in terms of preparation of the training curriculum, developing the criteria for qualification of the new cadre of community health workers, etc. And everything was intact. A few questions were pending on how this is going to be operationalized. And that is where the community-based health project that THET implemented was so much useful to answer that kind of question before the government decided to scale up this new cadre of community health workers. So from the project point of view, I don't think if they could suspect that changes could happen sooner or later within the period of implementation of the project. It became so abruptly, and it was unpredictable. Maybe this is something to learn. This is something to learn from this project, that in these countries where we are still growing, our health systems are still delicate and young, and every time they assume some new maturity, anything can happen. Usually when we run this big project, we do some risk assessment. And most of the risk assessment, most of the time, are directed towards looking at if the country enters into wars, if the country is faced with disasters, etc., etc. But less do we focus on predictability of policy changes, because we are convinced sometimes that the policies are intact. But unfortunately, these changes sometimes are not from the technical point of view. They are personal. When an office assumes a new person is sitting there, sometimes they come with new ideas, and they tend to influence and implement, regardless of the technical evidence that is available. Maybe this is something very strong we need to take forward in a big project like this, to not 100% be certain that the political dynamics are stable. They can change it and that. But just to be brief with that, I think the project had very little to do to predict this change.
Thank you very much, Selemani. I'm just jumping in. I have very limited connectivity. This is Grace. I was part of the team in the evaluation. Yes, Selemani has spoken very, very well and nailed it to the point. It's very true. I think at the beginning it was very clear this is what the government wanted and everyone was moving into that direction. Until later, when then everything changed abruptly and the policy changed. And so there was very minimal that THET could do. And of course, this was the main question that we kept asking when we were doing evaluation. How were the stakeholders who were doing CBHP in the country involved from the beginning during this policy change? And it came up very, like many times, that this was somehow due to some changes in leadership position and people not having a big foundation of what started and changing some of the things and the direction, of course. So yes, it's good to have those predictability assumptions and risks before the start of the project in fragile situations like Tanzania and other growing countries. Thank you.
Thank you. That's really helpful to know. Yes, because as you say, Rob, it was before Godwin started, and it was led by our Zambia team, but I was also involved. So I've always been asking myself, what else could we have done or explored? Thank you.
Thanks, Louise. May I just chip in, Louise? Very brief. Thank you.
Please.
Yeah. Thanks, team. Just to comment for a very good presentation. So I have like two things. So one, I wanted to add on the Louise points in terms of what we could have done. And I've realized this from a practical point of view when we're implementing the program. I think it is, I find out that there was sort of lack of a logical sequence of how the ministry had planned the activities. And so I think as partners, maybe if we're involved from the beginning, we could have a chance to help the ministry in terms of designing the activities. So a clear example is, for example, we went on training while we do not have the scheme of service, the policy that allows the community health workers to be deployed. So we go to a point where we struggled in deploying the community health workers. This was I think this was the biggest challenge overall, if I'm to assess the program. Again, we started training, the CHW graduated, we did not have the supervision guideline ready. So I think it is also, and not only for this program, but for other programs, I think it's just to think carefully when we are developing the programs in terms of what are the preconditions, for the program to be effective. Looking at, certain triggers, like for the community health workers. For example, do we have already the scheme of service to employ? Do we have the supervision guideline? So for us, we went on to roll out the production, the trainings, but at some point we kind of struggled a lot. I think that for me was a major lesson as well. But again, just to complement to Louise's points, I know it's difficult, but I think sometimes from the beginning, from the initial consultation with the government, when we want to start a program, is at least to hear whether there is a commitment of the core funding, for example, for this program. So what are the government bringing to the table? And this is common to many of the organizations here we see in Tanzania. So for this particular program, I think there wasn't clear commitment in terms of what government can actually offer, especially in terms of deployment, I would say, which goes to the point of doing a cost analysis of the program, which was done later, but was too late. UNICEF did a fiscal space analysis, but it came with very high cost, but that was already in the second year, I think, or third year. So the government was surprised and said, oh, we cannot afford to pay these salaries. So yeah, just wanted to bring those 2 points, just to add on what my colleague has just said. Thank you.
Okay, thank you everyone. If nobody else has any more questions, I'm gonna try to respect the time here, and we have about 1 minute left, so I think this is the right time to wrap it up. So I'll be communicating with Godwin to make sure I get the report and the tools to share out to everyone, and then as well as the recordings on workplace and for the trustees. So again, I'd like to thank Rob and his team for your presentation and your time today. We've learned a lot, and I really appreciate you giving us your time today.
Thank you very much.
Can I just say
Thank
one
you,
quick
Tim.
thing before we wrap up, which is I'd just like to say on behalf of our team, thank you to Salamani and Grace for making times in busy schedules to be part of this, but thank you to the THET team. I've already said this to Godwin and to Amma and others that were part of the evaluation team, but sometimes it's not an easy job being being independent and objective evaluators. But it was the THET team made our jobs pretty seamless, and it was great working with you all. So thank you. It's not very easy sometimes when you're trying to be objective and provide, you know, sometimes the findings and recommendations that we as evaluators sometimes come up with are not very well received. But that wasn't the case with THET and for this evaluation. So it was a pleasure working with you all. Thank you very much. And until the next time.
Thank you.
Thank
Thanks,
you.
Rob. Thanks, everyone.
Thank you, everyone.
Thank you.